Hello Dental XP members, nice to meet you again. So far, today I would like to introduce to you the new science Osteo-Immunology. Osteo-Immunology is radically changing our understanding of bone regeneration. It also gives us a highlight on the mechanisms of bone loss and peri-implantitis. Indeed, everything in bone is under the control of the immune system. It controls bone formation and regulates bone loss. Osteo-immunology is really a paradigm shift. It took me a long time, several years, to put in place all the pieces of this so complex puzzle. Because immunology is a difficult science, very complex. My aim today is to deliver a simple, easy to understand message and to bring back home. I hope that all explanation in this fascinating field will help you to increase your success rate and to avoid mistakes that can lead to failure or secondary bone loss. Enjoy! Sometimes we meet failures or complications, and we would like to understand why. In the literature, we don't have very clear explanations. So, bone loss, is it a fatality? No. What is the most frequent question? Why two surgeries made by the same surgeon with the same materials, with the same protocol, don't have the same follow-up? It depends on the patient's health. What's the patient's health? It reflects the patient's immune system. Then, what's a healthy patient? Usually we consider a healthy patient non-smoker, non-diabetic. A healthy patient is a patient with an efficient immune system. What's the immune system made of? We have two kinds of cells: hematopoietic stem cells and mesenchymal stem cells. Hematopoietic stem cells, they are located into the bone marrow and they have one specific function. They produce every day 100 billion derived cells. Every day, 100 billion. Which cells? We know them. The blood cells, platelets, red cells, white cells, lymphocytes, through the two progenitors, myeloid and lymphoid. The monocytes and the neutrophils, they organize the innate immune system, the system we are born with. The function of this system is to organize the defense against microbes and to organize the tissue remodeling and wound healing. On the other side, the lymphocytes, they organize the adaptive immune system. We say acquired after a time. What is the function? It's first to organize the cellular immunity with the T lymphocytes and the humoral immunity, the B lymphocytes, producing antibodies. The mesenchymal stem cells, we find them in the bone marrow, the fat tissues. The majority of adult tissue has muscles, teeth, synovium. What's their function? it's to regulate the two immune systems, innate and adaptive. How? By producing anti-inflammatory and immunomodulatory molecules during few days. Because the goal is to organize the tissue regeneration when they polarize the macrophages M1 to M2. Today, there is an evidence. Physical exercise improves the patient's health by mobilization of all kinds of stem cells. When we do exercise through the sympathetic nerve system, we stimulate the bone marrow, and through the muscles and the synovium, we organize the release of hematopoietic and mesenchymal stem cells going into the blood in order to modulate inflammatory and immune response. This is how we can achieve an efficient immune system with anti-inflammation, health improvement, and healing and regeneration. This is the action of the exercise. Then, which physical exercise is recommended? Walking. But we have more questions. At what speed? For how long? This publication from the British Medical Journal is interesting. They got 1,700 adults, 70 years old. They made two groups. One is walking 3 kilometers per hour, means 2 steps seconds, and one half is walking at 5 kilometers per hour, means 3 steps seconds. And then they followed the two groups during 5 years. After 5 years, in the first group, none are still alive. There is no survivor, 0. It means that walking not quickly will not improve the health. But the second group, walking at 3 steps seconds, after 5 years, all are survivors. And we understand that if we want to enhance the immune system and the health, we need to walk quickly. In the same reflection, this publication came to show that golfers, they have additional lifespan of 5 years because they walk often, quickly. But moreover, professional golfers, they are living 3 years more. Then we understand how the immune system is in charge of the global health by anti-inflammation, by organizing the defense, and by taking care of the wound healing and regeneration. Immune cells contribute to the early stage of angiogenesis, and we know how it's important, angiogenesis. Immune cells and factors are the key regulators in the wound healing. We are talking on osteology since almost 400 years. The first publication was made by Barthélemy Cabrol, French anatomist in Montpellier, surgeon of the king, and this book, Alphabet Anatomic, was the first to talk about osteology. And we were following this science during 400 years. But in 2000, we met a huge paradigm shift. Aaron and Choi, they came to publish on Osteo-Immunology. Means the immune system and the bone system are very close. What is the relation between them? Immune system is the key factor in bone homeostasis. Immune system controls bone formation by stimulation of osteoblasts. Immune system regulates the bone resorption by stimulation of osteoclasts. On the other hand, the bone system influences immune cells' function. And this is why we consider since only a few months that we have in our body only one system, and it's named the osteo-immune system. Wound healing and osseointegration, they start by inflammation, which is an immune reaction. And this inflammation will lead to the recovery and the new tissue formation. We need to know more about inflammation. We know that it's mandatory for the recovery. But the main information is that this inflammation must be brief, should last maximum of 5 days. During the first 5 days, the inflammation is always beneficial, and we name it positive inflammation, because it activates the repair genes, leading to the production of antioxidants, and this is how the immune system could be efficient. However, if the inflammation persists after the 5th day, it becomes harmful, and we name it the negative inflammation, because it increases the production of oxidant, leading to a deficient immunity, and this is how the wound healing will be compromised. Please keep in mind, as long as inflammation persists, as the healing is postponed. Inflammation must end at the 5th day, otherwise it will stay for a few weeks or a few months. This is the case of the keloids. After a surgery in the knee, the patient is still with inflammation and pain because the inflammation persists. If we stop the inflammation, then the recovery occurs very quickly in only 2 weeks. How the cells repair after injury? We need to activate the repair genes into the cells. We have almost 500 genes specifically, exclusively dedicated to the reparation. But we need to activate them by the master activator, which is the nuclear-related factor 2. When we activate this protein, we will increase the antioxidant production, leading to the downregulation of the pro-inflammatory cytokines. But we can start to put a very important information. What is the main activator of the nuclear-related factor 2? It's the vitamin D. And then we start to understand that vitamin D has a huge influence on the reparation and the healing. We will come back on this topic later. We talk about oxidant and antioxidant. What's an oxidant? It's a free radical named also reactive oxygen species. It's a molecule that has lost 1 electron or more, and then it becomes highly toxic. What's an antioxidant? It's a molecule able to promote and to provide 1 electron or more to a free radical in order to neutralize it. It means that we need to be in balance between oxidant and antioxidant. We produce continuously oxidant during the redox reaction, which are mandatory for life. And then we need to produce the same amount of antioxidant. We need to be in balance. But sometimes we can't, because we produce too much oxidant, or we don't produce enough antioxidant. The balance is negative and it's named oxidative stress. Oxidative stress leads to major cells issues, damaging membranes and DNA. Oxidant, they move into the nucleus and then they damage the cell's membrane and the DNA. Then the white cells are damaged with an immune deficiency, and the wound healing will be compromised. This is how we will meet higher rate of failures of or complication. What's the critical component of bone loss? It's the increase of oxidant in osteoblasts, because they will induce the failure of the bone remodeling. If the osteoblasts are not working, remodeling fails. And this is how we will meet a continuous bone resorption. Let's take one simple example of bone loss. After extraction, we know that the bone is not active mechanically. And what happens when the bone is not working? It becomes inflammatory. This is the wall flow. And we know what happens when the inflammation stays long term. The production of oxidant increases, leading to oxidation of the ridge, failing of the remodeling, and then this is how the ridge resolves. Simply. When we meet bad outcomes, any kind of bad outcome, it's because the balance is negative. We have too much oxidant following a long-term or intense inflammation, obviously associated with an immune deficiency. And if the immune system is deficient, it's logic to meet infection, to meet resorption. But now we understand why we meet fibrosis. Fibrosis follows all time a long-term inflammation. Long-term inflammation will lead to fibrosis and osseointegration failure. What are the origins of this oxidative stress? We said too much oxidant or not enough antioxidant. We will analyze all the situations. First is, now we can explain most of complication. First, diabetics and smokers. We know that this patient, they are meeting more complication, more failures, because they are in oxidative stress. Diabetes is first a chronic inflammatory disease with high level of oxidant, but diabetics are also deficient in vitamin D. What is the issue in smokers? The issue is the smoke, because the smoke breaks down the antioxidant of the gum, making the gum oxidized. This is why the gum of smokers doesn't heal well, but they are also deficient in vitamin D. Chronic inflammatory disease, diabetes, chronic inflammatory and autoimmune disease, obesity, they have a high level of inflammatory cytokines, and this is why they will meet more infection and failures. Hypercholesterolemia. We know the cholesterol. We have two kinds of this lipoprotein. We have the HDL, which is good, and the LDL, which is bad. The HDL is good because it's an antioxidant. And the LDL cholesterol is bad because it's an oxidant, making the osteoblast oxidized. What is the relationship between osteoblast and cholesterol? The metabolism of the cholesterol occurs mainly in osteoblasts. And this is why if the cholesterol is high, the LDL, it will induce osteoblast oxidation. So if the cholesterol is above 1.4 gram per liter, the osseointegration will be delayed. But if the cholesterol is above 1.8, I want to tell you that even in dream, you will never meet osseointegration. This kind of level is totally inducing complication and failures. When we have a high level of LDL, the osteoblasts are oxidized and then they don't work. But we know from where they're coming. They're coming from the mesenchymal stem cells. And when the osteoblasts are not working well, most of stem cells are going to produce adipocytes, fat. And then in this situation, the bone is replaced by fat and becomes with a yellowish color. Sometimes when you raise the flap, you see that the bone is yellow, but you don't understand why. Brannemark, 40 years ago, he was teaching his students, telling them, you know what, when I see a yellow bone, I cancel the procedure. Why, professor? Why do you cancel? He was telling them, I don't know why. What I know is that when I raise the flap and the bone is yellow, I will meet a very high level of failures. And then, if I see a yellow bone, immediately I close the flap and I do nothing. This is why I recommend to test the LDL before the surgery. It must be less than 1.4 gram. And if it's increased, then you should send the patient to the physician. We know that allergic to penicillin are meeting a lot of issues. 50% increased risk of surgical site infection. 3 to 4 times more failures in implantology. Almost the same than in diabetics and smokers. Almost the same. And if we change the antibiotics and we use, for example, clindamycin, we will meet the same rate of failures. Today, we can explain why. Allergy is a dysfunction of the immune system. What happens? And we know that since the consensus conference in 2014, there is a long-term release of inflammatory cytokines by the T lymphocytes. And we know what happens when we have too much inflammatory cytokines. We will increase the oxidant production. In the same time, allergic are deficiencies in vitamin D. And we know that with deficiency of vitamin D, they will not be able to produce enough antioxidants. And then the conclusion is very simple. They are in oxidative stress and they will meet more infection and failures. Sometimes we do a surgery and at the opening we see some resorption and some fibrosis. Can we explain how and why? When we do a bone augmentation, what is the key point? It's the state of the gum. And if the soft tissue is thin, then we know that the bacteria, they penetrate and spread to the periodontium, making this periodontium inflammatory. We don't see, because we see the epithelium, we don't see the periodontium. And if the periodontium is inflammatory, it will release the cytokines on the bone, making this bone oxidized. And we know what happens when oxidation occurs for long term: resorption, fibrosis, or both. A collagen membrane is recommended to be placed on the graft. What is the real function of the collagen? The function of the collagen is not to avoid the penetration of the cells from the flap, from the soft tissue. This is not the biologic mechanism. The cells from the flap, they can't move into the bone. What happens when we place a membrane? It's for making an immune barrier, stopping the inflammatory cytokines coming from the soft tissue. And this inflammation will be the origin of the connective tissue. I will explain you later. So, we understand that the fibrosis or the resorption is due to the inflammatory gum. But it means that if the gum is not inflammatory, if the gum has enough thickness, enough keratinization, do we need a collagen? My answer is no. There is no cytokines. And this is how we can now understand the indication. If the gum is not inflammatory, if the gum is enough thick, we don't need to place a collagen membrane. And you know that we have already a collagen membrane, natural. It's the peri-implantitis. In the books of biology, peri-implantitis is named a collagen membrane. But it opened our eyes today to understand some issues. Usually when we do autogenous bone graft, we don't place collagen, because we believe that as the bone is autogenous, we don't need collagen. No. The behavior of the graft depends on the soft tissue inflammation. And if the soft tissue is inflammatory, you will meet resorption, even if the bone is cortical. It means that even when we make an autogenous bone graft, we should place a membrane when the soft tissue is too thin. Look, a screw was placed to make a screw tenting, but if the soft tissue is inflammatory, the resorption will occur. We place a biomaterial and we can meet a foreign body reaction. It's a response from the innate system. And then when the inflammation persists, the monocytes, they become macrophages, and the macrophages become foreign body giant cells. It means that the compatibility is related to the inflammatory response. As inflammatory response increases, as the compatibility fades. This is what we need to have in mind. Let's go to analyze the inflammation induced by biomaterials. We have three factors: origin, cleaning, and porosity. First, the origin. When we use low inflammatory material as human or porcine, we meet a low level and short time inflammation. Why porcine is low inflammatory? Because antigenicity is very close to human. When we use inflammatory materials as synthetic or bovine, we will meet a long-term inflammation, leading to oxidation. And this oxidation into the graft will be the origin of the connective tissue growth, the fibrosis, or the encapsulation. The connective tissue growth is not coming from the flap. The connective tissue growth is built by the fibroblast into the inflammatory bone graft. Then, using an inflammatory biomaterial, you will meet a delayed osseointegration and maybe fibrosis. We need to take care about the surface condition, means the cleaning. We do with implants and titanium, we must do with biomaterials. This is a surface condition of 3 bovine, and we see that the cleaning is not very good. We have a lot of debris, and what we will do when we put debris, we will induce inflammation in order to remove this debris. Even in porcine, we have some material which are not very well cleaned. Then we can go to the porosity. We have 2 kinds of porosity, the macro porosity and the micro porosity. When a company shows you a picture of bone, telling you, look, it's the same than human. Of course, bone is bone. It doesn't matter from where it's coming, animal or human. It's bone. And the macroporosity of bone is always the same, whatever from which animal it's coming. But let's go to the microporosity, which is around 1 micron. We have 3 bovine, and we see that 2 of the 3, they lost the micropores. In the porcine, we have the same. 1 lost the micropores, and 1 has still all micropores. But why the stability of the micropores is not met? Because of the heating temperature. When we heat too much, the micropores disappear. And we must be focused on this, because the micropores, they allow the fluid from the blood to pass through, and this way they will bring the proteins from the blood. And if we don't have micropores, behavior will not be very good. To understand, when we heat at very high temperature, the biomaterial extracellular matrix is totally modified, as you saw in the pictures. And then the innate cells, they don't recognize it. It's the same with synthetic. This is why synthetic are the most inflammatory biomaterial. Don't believe that synthetic is safe. Synthetic is very inflammatory because it's a full foreign body. And if the cells, they don't recognize this crystal, it will become a high level and long-term inflammatory material. We can meet oxidation after long-term ischemia. How a tissue turns ischemic? We have the answer from Mamoto. After her paper in Nature 2009, and she said when we applied pressure or tension, it will lead to a loss of vascularity. Yeah. If you want to lose the vessels, just press or just pull in order to make tension. We have the examples of the bed ulcers. When we apply a constant pressure on skin, the necrosis is mandatory. Tension or pressure leads to ischemia and hypoxia. Then we meet oxidation, and oxidation leads to bone loss by the failure of the bone remodeling. Tension. Soft tissue, when it's in tension, it becomes ischemic and it will induce bone loss. This is an example of peri-implantitis. If we take a look on the soft tissue, we see that there is no vestibule. Bone loss follows chronic tension. But we can meet ischemia by unreasonable pressure, means inadapted torque. But the torque does not affect the bone in the same way. The bone reacts to pressure according to its density. This is the law from Hooke, who published the law more than 350 years ago. Bone tissue reacts to pressure according to its density. When the bone is soft, flexible, we will not meet stress. But when the material is dense, rigid, we will meet a high stress. And then in the bone, when it's cancellous, it's flexible, and then the pressure will not induce oxidation. We can put torque on cancellous bone. But on the cortical level, this bone is very rigid, and then the pressure will induce high stress and oxidation. If we take a look on the 4 implants with peri-implantitis, we will see that the resorption always takes place in the cortical zone. When we place an implant, what is the critical zone? It's the cortical zone, because this bone has no plasticity. This bone has a poor blood supply, and then pressure will induce oxidation. And this is how occur the marginal bone loss, by the pressure on the cortical bone. Marginal bone loss starts with compression of the cortical bone. This paper, published by Dweck, showed that high torque induces a broken and ischemic bone. If we don't place any torque, the bone is really healthy and not ischemic. We have another publication from Tabassum. He wanted to see, after placing an implant with an undersized drilling, 5%, 15%, and 25%. Undersizing preparation of 5% or 15% does not affect the bone behavior. But when the preparation is 25% less, then we will meet an impair of osseointegration. When the cortical is sick, what happens? the implant, press the cortical and oxidize it. Then we will meet a cratering, because the cortical bone does not support any pressure. We do bone graft, and we do two frequent mistakes. The first is to believe that the bone graft must be very dense at the reopening. The second mistake is to place an implant with high torque, believing that the stability is the main factor. No, high torque will induce high stress. The bone graft is not flexible. Then it behaves as cortical bone, and any pressure will be fatal. We know the osteonecrosis of the jaws when people are taking biphosphonate. What is the main cause? The main cause is the immune dysfunction, related pathways associated with biphosphonate. When they take biphosphonate, there is a disturb of the mucosal and osteoimmune homeostasis, leading to infection and then osteonecrosis. So we understand the mechanism. It means that now we can propose solution. We need to enhance the immune response, and we need to avoid immune dysfunction. How to set osteoimmunology protocols? Because we need to propose some protocol. For us, it's very easy. We just do what the biology likes. That's it. How to enhance immune response? We know that if we want to do that, we need to increase the antioxidants in order to shorten the inflammation. This is the way. We know the nuclear-related factor 2. We need to activate this protein. And the activators, they have the potential to control the inflammation-driven bone loss. The NRF2 will go into the nucleus on the genes, activating this in order to produce antioxidant. And they will go to neutralize all the oxidant into the site. The most powerful activator of the nuclear-related factor 2 is the vitamin D. Numerous genes determining immunity and bone growth and remodeling are vitamin D dependent. Vitamin D protects the cells against oxidative stress damage. I'm running all over the world since almost 15 years to ask my colleagues, please test before the surgery the vitamin D. Please organize a systematic supplementation according to the serum level associated with the cholesterol. What is the pathway? We know that we produce vitamin D after sun exposure, or we take it by diet, and then it goes to the blood, through the liver and the kidney, with 2-hydroxylation and becoming an active hormone, 1,25-dehydroxy vitamin D, making an endocrine activity on the calcium metabolism. But today we are more focused on the paracrine activity, which is the anti-inflammation and antioxidant product. We need the vitamin D to improve the immune system. The serum level minimum is 30 nanogram or 75 nanomole per liter. Take care when you take in the hand the blood test. Is it in nanogram or in nanomole? Not the same. Below it's insufficiency, and below 10 nanogram it's a deficiency. But a lot of people are deficient today. At least 70 to 80% of the population. Why it's so frequent? Because at the beginning, humans, they were living naked, taking the sun every day. And today, this is the human modern. Clothes, cap, bird, glasses. And they invented recently another way to decrease the sun exposure. Tattoo. Yeah, humans are crazy. Below 20 nanogram, vitamin D deficiency has a causative role in the systemic inflammation. This is a case of implant, and they were stable during 6-7 years. And then patients started to lose the bone. When we checked the blood, we saw that the cholesterol was high and the vitamin D very low. When we lose the bone around the implant, we understand why the remodeling phase around the implant, because of the biologic situation. And this is why we need to test before. Supplementation from 2,000 to 10,000 units a day. It depends on the serum level, but it depends also on the patient health. Do this patient is in oxidative stress, smoker, diabetics, allergic, then we need to give them more because they are very deficient. But we have other activators. Vitamin K, it enhances the vitamin D efficiency. We know the antioxidant action of the vitamin C. We know how this fantastic hormone is antioxidant. Zinc is mandatory for producing antioxidant enzymes. Without zinc, with a deficiency in zinc, the immune response is deleted. But we have also other pathways to produce antioxidants. Not only the nuclear-related factor 2. We know the influence of the microbiota on the immune response, and then probiotics will help us. Vitamin E has a huge anti-inflammatory function. Copper, magnesium are very powerful in anti-inflammation, and the omega-3 fish oil. It's very, very anti-inflammatory and without side effects. So now, if we want to achieve a powerful antioxidation, we can do it. We can improve the immune system and the repair capacity. Today we have a product that was designed by Immune Pharma. It's the Immune Force. It has all the products that I showed you. All the products. And this is a cure of 2 months. They will take 1 pill every day of each vial. Simply. They will have all the products. But you know that the manufacture of antioxidants takes time to start. And this is why we need to start the supplementation at least 1 week, 10 days before the surgery. And then they will follow the cure during 2 months. They can continue it after if they want. Can we improve the immune response with antibiotics? This is a good question. We know since 40 years that macrolides, they have an immune function. And what we saw during the COVID, we saw that in all the countries, the azithromycin was used. At the beginning, my question was, COVID is a virus. Why do we use an antibiotic? Then I came to the literature, and I saw that azithromycin has the most powerful immunomodulation. And then I said, now I understand why we give azithromycin, because of its immune function. And I said in my mind, I need to test in clinic. Fortunately, just after the lockdown, a first case came. Patient allergic to penicillin, candidate for a bone augmentation, vertical. Then the surgeon replaced the amoxicillin by spiramycin because he was allergic, but the preparation was not very good. And the patient came after 6 days with a monumental infection. Pus, pain, swelling. And then the surgeon called me in order to get an advice. I told him, do nothing. Just give him azithromycin. Wait 2 days. With azithromycin, 3 pills today and 3 pills tomorrow. That's it. And we will control the patient in order to see what happens after 2 days. Give him vitamin D, 50,000 units, it will help. And the patient came back after 2 days without any abscess. The abscess was gone. After 1 week, the recovery was full. But the surprise was, after 3 months, the graft, the vertical graft, was a success. It's unbelievable. It was the first time in my life that I saw that an abscess can be a success 3 months later. Then we need to understand, we have 2 kinds of literature. Literature after the COVID and literature before the COVID. Literature after the COVID is showing that azithromycin inhibits oxidative stress. Now we understand why we made this kind of case. Azithromycin is more efficient than amoxicillin in prophylaxis. Interesting. But what we missed before the COVID? We missed that the azithromycin use is very easy. 1 dose of 1 gram is active for 1 week. Means when you give 1 gram, it's enough for 1 week. We don't need to give 2 pills every day during 1 week. 1 dose, it's enough. The main target of the azithromycin is the soft tissue. Accumulation of soft tissue into the polynuclears and the fibroblasts with a ratio more than 100 between intracellular and extracellular. This is the power of azithromycin. And then we started to involve azithromycin in our protocols. First, mixing azithromycin and amoxicillin, but only after a few months we stopped to use amoxicillin. I can share with you now the updated protocols that we use in 2024 after 4 years of test and correction. We use 1 box of azithromycin in all indication, and we have 3 courses of medication. We give them 2 caps the night before, 2 caps 1 hour before, and 2 caps at the 5th day. Why at the 5th day? Because we would like to increase the positive inflammation, you remember. This is how we work today. But we don't forget that when we have an inflammatory gum, or when we have a very thin biotype, we should increase the azithromycin time. It will be taken for longer at 0.5 gram per week during 2, 3, 4 weeks more in order to reduce the periodontal inflammation. We know that patients allergic to penicillin, we need to change. We will use azithromycin with the same protocol, 2, 2, and 2. But it's not enough. We need to be careful because these patients are in oxidative stress and we need to mandatory add an immune supplementation. I would say minimum is vitamin D supplementation. What gum loves most? To put azithromycin powder on the graft, on the sticky bone, or just on site before the closure. Where to find azithromycin powder? Just go to the pharmacy. They have azithromycin for kids, and it's a bottle of powder in suspension. And then you will use a little bit of powder. Please ask your assistant to systematically put a bit of powder on the table in order to do not forget to use it at the end of the surgery. I published several years ago the use of metronidazole topical. It was efficient, but today we don't use anymore because azithromycin replaced the metronidazole. It's much more effective. Let's go to see some clinical example. This is a case with implant in the mandible, and this is after 4 days. We can see how is now the inflammation. It's gone. We are in the time of the positive inflammation. In this case, we have a huge infection, implants were placed, bone graft, full graft of the maxilla, and then we can see how is the healing after only 3 days. This is what we were doing before. Using PRF and other stuff, the healing was very good, but today, when we introduce the topical azithromycin, what do we see? Faster healing and better gum thickness. This is what we did before. Using PRF and deep sutures, etc., we were happy. But when we started to introduce the topical azithromycin, we can see how the healing is faster and how the soft tissue is much better. What is the mechanism? Why azithromycin is so active? First, gingiva is a niche of stem cells, both hematopoietic and mesenchymal. And into the sulcuses, the gum produces around 45 to 50 millions of white cells every day in order to improve the immune function of the gum. What is the action of the azithromycin? It induces immunomodulation, and it concentrates specifically into the gingival polynuclears and fibroblasts, again improving the immunomodulation. Finally, the gingival immune response is extremely enhanced, and this is why you will meet faster healing and better soft tissue thickness. Can we improve the immune response with autophagy? What is autophagy? Ozumi got the Nobel Prize in 2016 after his publication, showing that when a cell is in fasting, this cell will start to remove all the unwanted substance. Means the cells, when they are in fasting, they detoxify their own. Yeah, fasting is a physiological detox. And we have today a huge evidence about the improvement of the innate and adaptive immune system by the autophagy. Autophagy accelerates the wound healing through angiogenesis. The question is how to induce autophagy. We need to be in intermittent fasting. What is intermittent fasting? We are in fasting at least 16 hours. 16. It's long. It means 2/3 of the day. Is it easy to be in intermittent fasting? The answer is yes. We just need to miss the breakfast. What is our protocol? We ask them to start intermittent fasting 5 days before and to stay 5 days after. It's enough, 5 days. The surprise is, because we use this protocol since more than 2 years, is that when the patient they start, they come later to us. Hey doctor, you know what? I'm feeling so well. I will not stop. I will continue to be in intermittent fasting. Should we use steroids? Of course. It's beneficial. Because the cortisone shortens the inflammation. And this is what we want. As the inflammation is short, as the healing is better. But before we were thinking that giving cortisone several days was good. No. Today, we understood that we need, in order to reduce the inflammation, to increase the antioxidant, but then the cortisone is used with a single dose. It's enough. 1 hour before the surgery, we give them prednisolone, 1 milligram per kilo, or, if you want to inject it, dexamethasone at 0.2 milligram per kilo. 1 single dose, it's enough. It makes sense to order physical exercise, to ask them to walk 30 minutes a day, but quickly, 3 steps a second. I believe that they will do, and this is what we see today. When we ask the patient, they say, yes, I will do, because we explain why. We ask them to start 5 days before, and at least 5 days after. Daily, 5 kilometers per hour, 30 minutes. And then we see people coming back. Hey doctor, you know what? I'm feeling well. I will not stop. We are happy of that. The first was to improve the immune response, but then we need to avoid an immune dysfunction. Immune dysfunction occurs when we meet tension, ischemia. And then we need to manage the flap in order to remove the tension. How to do that? By an over-release. We need to release more than necessary. We need to take care about the tension during the closure. But the question is how to assess the tension when we do a surgery. We don't have any device, like when we use the instrument for the implants. we don't realize that when we inject anesthetics, we make the muscles flat. And then the tension that we want to see is much less than the true tension. But if we want to see exactly how is the tension, we just need to pull the lips. And then you will see two things: the tension and the mobility of the flaps. This is how to assess it. If you pull the lips, you will see how the flap is mobile and under tension when the patient are smiling, coughing, speaking, eating. This test is mandatory at the end of the surgery. And then how to fix the flap, because the flap is mobile. We need to use a specific technique. I designed the apical mattress after my meeting with Mamoto in Boston. I understood that we need to remove the tension, mostly in the buccal flap. And then I proposed an horizontal mattress, but very deep into the vestibule. Means at 1.5 centimeters from the margin. This is an apical mattress. We go on the flap, we go back, and then the outlet of the needle is at the same level. This is why we say this is an horizontal mattress, but very deep into the vestibule. Do we need to go very deep into the lingual or the palatal? No, it's not necessary. And then we can see how we can block the mobility and indeed the tension. This is a case full arch with classic sutures. And we see that the whole buccal flap is mobile. If we change by apical sutures, we will see that the flap is totally fixed. We remove the tension and the mobility. We see that the flap is mobile around the abutment. If we add an apical mattress, then the flap is fixed. This is a situation of full arch before the primary closure, and what we see that there is no mobility and no tension. Before the primary closure, we pull the lip, and then we see that we are so efficient on the tension removal. This is the best to avoid tension in the buccal flap. But at the same time, when we tighten the threads, we make a coronal translation of the buccal flap and then of the periosteum. And when we close, we have an excess of soft tissue. And we are creating an increase of the thickness. Simply, by a suture, you can increase the thickness of the soft tissue. I want to show you. This is in the maxilla. We go inside into the palate, we go back, and then the outlet is horizontal, 1.5 centimeters from the margin. And then when we tighten the sutures, we see the thickness increase. But in the same time, we see that we have too much soft tissue, more than necessary. Same in the mandible. When we tighten, we see the increase of the thickness. Same time, we can see the lens. We have too much soft tissue. Then we are sure that when we do the primary closure, we have zero tension. A case to show you the benefit of this kind of suture. This is a case of a lady who got extraction, and the surgeon put a PTFE membrane, and she got infection. We removed the PTFE because she was in another country and she came in our country. And then we waited a few months to come back to place implants. But when we raised the flaps, we saw that the socket did not heal well. It's impossible to place any implant. Then we need to manage the site in order to heal. We propose to use PRF, but we know that when we do flaps, we know that we have a risk of bone loss. We have a buccal flap and we have a lingual flap. But the solution was to use an apical mattress, very deep, in order to stabilize after filling the site with PRF. And this is after 3 months. We see the increase of the ridge thickness because of the apical mattress. The apical mattress designed a space fixed with the periosteum, and then it was filled by bone. You see that we can increase the thickness of the ridge without bone graft, just by using a special suture technique. Question is when to remove the threads. I don't have a personal opinion. I know that often the threads are removed too early. We must wait the periosteum reattachment in order to do not meet any mobility. But how much time it takes to reattach? At least 1 month. 6 weeks to meet a significant reattachment. 6 weeks. It means that for me, we must leave the threads 4 weeks. It's obvious that we can't use silk or any braided suture when we leave the suture for 4 weeks. The only one solution to use a monofilament. And we can see the difference into the inflammation of the soft tissue when we use a monofilament. Then, can we use a non-absorbable monofilament? Yes, but after 4 weeks, the threads will be embedded into the gum. It will be difficult to remove them. Then there is only one solution, is to use an absorbable monofil. There are plenty of monofil absorbable. This one has just the ideal resorption time, 4 weeks. No pressure on crest and bone. This is what we should do all time when we do the preparation for the implant. Over drilling just in 2 millimeter height. Why? In order to avoid any contact between the implant and the cortical bone. But we have another benefit. We know that this space will be filled by blood, clot. And we know which quality we will get around the implant in this situation. We will get the best quality of bone, a vital bone. Then we replace around the implant, we replace the cortical by a vital bone. We can do this kind of overdrilling by a contour sink. Branemark designed the contour sink 40 years ago, And today, a lot of people, they want to forget it. It's still valid. You don't have a countersink, use a larger drill and go just 2 millimeter depth in order to avoid any contact between the implant neck and the cortical. Subcrestal position is very good, and I would say subcrestal and overdrilling is the best way. But where do we start before implantation? We need to assess the cortical thickness. It's very important. We have, the classification from l'école Mansard, class 1, class 2, class 3, and class 4. Before implantation, we need to assess this cortical thickness. If the cortical bone is thin, then we can place implant. We can torque it, and we can load it immediately. Just make the overdrilling the crestal. But in this bone, in this thick bone, forget to place with high torque. Forget the immediate loading, because if you do that, you will lose the implant in the future. We need to assess, because we will anticipate the bone stress. Placing the implant is showing us what will happen. Stress into the cortical bone, and then we need to go with a reducer torque. We need to overdrill the crest, and we will never do, even in dream, the immediate loading. Look, this implant was placed in the right way, means no stress. 10 years later, we have still the bone above the neck. There's implant were placed in a thick cortical with high torque, and you can see the follow-up. And you understand that we need to take care about this issue. We want to place implant after bone graft, and we know that any compression will be fatal. Then, if we do it, we will lose, definitely. When we press the bone graft, we will lose the bone, even if it's a calvarial graft. 4 implants and full resorption because the surgeon placed the implant with high torque. Even if you use BMP, we forgot this concept. But even if you use BMP, you can meet a dense bone. It will not give you the stability, because when you press a dense bone, you kill this bone. A case with augmentation with screws, and the surgeon waited 1 year to reopen. And then when I met him, I said, Joe, why did you wait so long? He told me, I wanted to meet a dense bone. Okay. And then I lost everything. The concept to wait long time to meet a dense bone is not valid today. First, we will place the implant with reducer torque, we will never make immediate loading, and we will overdrill the crest. But today, we prefer to re-enter very early, means around 2 months. You see, the implant is placed with a reducer torque. You see, the overdrilling is mandatory. And then, 5 years later, you can meet the whole bone. This is how we protect the bone. We need to avoid the flap pressure. You know, when we make augmentation, the flap press the underlying bone. And then we have different techniques that avoid the pressure from the flap. I name them protective bone regeneration. It's the case of the Curie technique. With the titanium, it's the same. The mesh does not allow the gum to press the particulate bone inside. The PTFE is the same. When we use screws or when you use mesh, we can do very simply by screws. And this is how we can maintain the volume, because we remove the pressure by the screws. We need to shorten the inflammation, which is coming from two origins: the graft mobility and the foreign body reaction. When we place the graft, we know that the muscles in the face will induce mobility of the whole space. And we know what happens. The bone callus is fragmented, and then in the same time, the vessels are cut, and the bone becomes highly inflammatory. Then we can use the sausage. It's very good, because we fix the bone, and it's not mobile. But we can use the sticky bone. The sticky bone will help us to maintain the bone, or we can use both. The concept is to do not, and also the sutures will be helpful. The PRF, we know the function of the fibrin. It's the support for cells, for migration, for differentiation. And we know that the fibrin is the first place of the new vessels born. Today, the solution is the sticky bone, because the sticky bone will help us to use a graft which is first compacted, strongly compacted, and then we will use one piece of bone. When we do an augmentation, we use one piece. We can use also a sandwich of bone between two layers of fibrin. There are different techniques of sticky bone. We use today the palm swing in order to make a sticky bone express, and then we can place it into the site. What are the recent publications? They show that PRF improve angiogenesis and reduce inflammation. And then the conclusion, our conclusion nowadays, PRF is a powerful anti-inflammatory and it's an antioxidant. Recently, we got from Myron a publication showing that horizontal centrifugation will produce 10 times more cells. How to believe that just the angulation will increase the cells? He started with 10-fold and now he's with 4-fold. But I can tell you that there is no evidence today. Because all the papers about horizontal were published by Myron, and the other papers are showing that there is no difference. There is no difference between, and it's logic, because how to believe that just the angulation will produce a different tissue? Today, there is no benefit in horizontal centrifugation, but I want to tell you, it's better to move to the osteo-immunology. This is the way to improve the outcomes. This is the way to avoid failures and complications. We should minimize the foreign body reaction. Today, the best choice is to use human or porcine. That's it. Because we want a short-term inflammation. Allografts are very used, but we have just one issue into the stability of the volume. This is the only one thing that we don't have good with the allograft. And today, new porcine materials are coming to give us products that induce a low foreign reaction because they are from porcine. They are very well cleaned. They are not heated at high temperature, and they give the volume maintenance. You should try the Purgo material. Does it make sense to mix biomaterial with autologous bone? Because we see a lot of people that are mixing. No. If you use a non-inflammatory material, like allogenic or porcine, you don't need to mix, because you can use the materials alone. But if you use an inflammatory material, you should mix in order to reduce the inflammation from the bovine. This is what some people they do today. But 50% of autologous will not decrease 50% of the inflammation. And this is why they want to increase the ratio, 60-70% of autogenous and 30% of bovine. But it's still not enough. Inflammation is still there. Solution is just to avoid the bovine material. This is a case made by a friend in Portugal. He made the augmentation in the maxilla with a PTFE and look at the 3 months reopening. No mixing, no autogenous bone. We don't need when we use a non-inflammatory biomaterial. For osteonecrosis, you understand that it's an immune disease, we need to supplement. Minimum is vitamin D, but both are much better. And PRF will help. This paper published in Bone last year showed that PRF reduced the risk by 84%, the risk of osteonecrosis. This is the way. For example, a case of osteonecrosis starting after extraction, the treatment is very simple. Cleaning and using PRF. But the mistake is to try to close the flap. No. Please, leave open, because the fibrin will do the job, means making a new tissue and giving you a full healing after 3 months. Now, as I told you, it took a lot of time to put all the pieces from the puzzle in place. We just published this paper in Bioengineering, which is a conclusion of the whole Osteo-Immunology in oral surgery. And you can download the paper with this link. Let's go to see the puzzle. The objective is the remodeling, because remodeling is the guarantee of the bone stability. We need both osteogenesis and osteoclastogenesis. The first condition is to have enough antioxidant. Because with the antioxidant you will get the immunity, and with the immunity you will get the vessels. Simply. If you want to maintain the vessels, please don't kill them with pressure or tension. If you want to increase the antioxidant, I gave you the solutions. Vitamin D, PRF, autophagy, physical activity. And if you want to meet a good immune response, please remove all the inflammatory biomaterials as synthetic and bovine. Gum sickness will help, azithromycin will help. So now, what are the benefits of this protocol? We can leave the wound open without fear of infection. Extraction, we can put PRF and leave open, but look, the condition is the suture, the apical suture. And then you can rebuild the whole ridge, just with fibrin. Same case. You see, the buccal bone is missing, we leave open, we stimulate the immune system, and then we get the full ridge, regeneration. We can put bone graft into the socket, and we will cover with PRF, of course, and the goal is to get a good soft tissue, keratinize. This is the goal of, one of the goals of the open wound, but the bone is still there. When we see this position, this T position, we know that we will not be able to close, to make the primary closure. But it doesn't matter, because we know that today, with the Osteo-Immunology protocol, we can leave open without fear, getting the soft tissue and the bone volume. Bone augmentation with screw tenting. It's difficult to achieve the primary closure. It doesn't matter, we will leave open. And look how the gum will come to close the site. We cannot close, then we leave open, just by using the Osteo-Immunology protocol and the PRF. And we will get the keratinized tissue and the coverage. When we want to improve the soft tissue thickness, we can do the connective tissue graft, but we can use the open wound technique. We use the blood stop and the acrylic glue, and then we can improve the soft tissue thickness without making any management of the soft tissue. When we have infection into the site in the posterior, of course we will not put any bone graft. We will use only PRF, and we will use the open wound technique. Then 3 months later, we can place the implants because we fill the whole side with bone. This is a very demonstrative case. Simple case, implants, but the soft tissue is not enough thick. Placing the implants, using the poncho technique, and then leaving open. But the apical mattress is mandatory. And then after 2-3 months, we can see the quality of the soft tissue and the keratinization. We can use the PRF when we want to make a vestibuloplasty and the open wound. We do the split incision and we fix the flap to the periosteum. And then you see that the site is completely exposed. We can use the fibrin matrix. We can use the fibrin matrix because we know that it's a provisory extracellular matrix. We need, of course, to fix it. And in 1 week, we will get the new tissue, the new keratinized tissue, in the full vestibule. So, we can go to the lessons. What is the first? Immunity is mandatory. If you want disintegration, if you want to maintain the bone, and if you want to reduce the complication rate. In the last meeting in Nice, in June, my meeting, the SciFac, my friend Nicolas Davido came to show us 200 cases of autogenous bone graft, because he's doing, like Curie, only autogenous bone graft. And he showed that with the osteo-immunology protocols, he reduced by 90% the complication rate, just by changing in his practice some protocols, not changing the surgical technique. The major benefit is painless. People that will come to tell you, doctor, I didn't feel pain. Good. How many pills did you get? I did not get any pill. Even the day of the surgery, even the day of the surgery. Why they are painless? Because we reduce the inflammation from the first day, because we started before. And with low inflammation, there is no pain. The third lesson from osteo-immunology is that now we understand why we lose the bone, because of the immune dysfunction following the oxidative stress. And then it's easy, very easy for me to say peri-implantitis is an immune disease, bone loss is an immune disease, even after prosthetic issues. We know the prevalence of the peri-implantitis and mucositis. 31% of peri-implantitis, 47% of mucositis. This is an immune disease. But how to explain this immune disease? Again, bone loss follows immune deficiency. Then, chronic inflammatory disease will induce immune disease. Pressure on bone will induce immune disease. Tension will induce immune disease. Soft tissue incompetency will induce immune disease. First, chronic inflammation. Long term, followed by bone remodeling failure. We know all the pathologies that are making a chronic inflammation or reducing the antioxidant production. Then, when you have a patient like that, if he has high cholesterol, you can reduce. But if he's diabetic, you cannot change. If he is allergic, you cannot change. How to improve? Even the smoker, by antioxidation. You can improve, enhance the immune system of this patient by antioxidation. Immune force today is the best way. Peri-implantitis follows pressure on bone. Who is responsible? Who is pressing the bone? The surgeon. It means that the peri-implantitis is scheduled the day of the surgery. How to prevent? No pressure, that's it. On the crestal bone and on the grafted bone, both. I like to comment this picture. Why in the same patient, in the same mandible, we have one living implant and two peri-implantitis? Because of the different pressure on bone. Tapered implants are making much more pressure at the neck, where is the cortical. And then when you place a tapered implant, you press more. This is why the over-draining is mandatory. The cylindric is much less aggressive. And then it could be safe. Tension induces bone remodeling failure because the flap release was not sufficient, because the sutures were not efficient. Again, who is the responsible? The surgeon. Means the peri-implantitis is scheduled the day of the surgery when you don't manage the tension. Simply. How to prevent? Over-release, apical sutures, and if you cannot achieve enough release, leave open. It's much better to leave open than to try to close. Of course, leaving open needs the help from the PRF, from the fibrin membranes, and also from an osteo-immunology protocol. Immune disease can follow a soft tissue incompetence. What does it mean? Incompetency. It's the incompetence to avoid the bacteria to penetrate into the periodontium. An incompetent tissue is a thin biotype. Soft tissue sickness has influence on the severity of bone loss because as the soft tissue is thin, as the bone loss is more important. Then we can try to find how many people are living with a deficient biotype. Look, 1/4 of men, half of women. It means that 1/3 of adults are natural candidates for peri-implantitis because they don't have the right soft tissue to avoid inflammation. Peri-implantitis soft tissue must be reinforced. This is a concept of the zero bone loss from Linkevicius. I agree. If the soft tissue is not competent, the bone will go on. However, bone loss can occur despite tissue has enough thickness, because when the implantation is made with too much torque, when the tension stays, we will lose the bone. And this is what published by Claudio Stacchi and the team from Emerly and Thomas. So, the conclusion is simple. If the soft tissue are not managed as well in this kind of case, peri-implantitis will be scheduled the day of implantation. And this explains why we have so many peri-implantitis, because the soft tissue is not managed as well. Finally, who's the main responsible of peri-implantitis? The surgeon, because he's doing a wrong surgery. And if the surgeon follows all the rules, I mean all the good rules, no pressure during implant placement, no tension on soft tissue, controlled biology, and then, after a few months, he will get an effective periodontium, which is a sick periodontium. And then, what will happen after 15 years? Nothing. Even after 14 years, there is no reason to lose any bone. After 13 years, there is no reason to lose any bone. Then we can talk about the treatment of peri-implantitis. It could be surgical, then it will be only a management of the periodontium inflammation. First, you should start by improving the patient immunity, cleaning the surface of the implant, and increasing the soft tissue thickness. In this case, if you do not increase, you will meet again a new peri-implantitis. we should use a non-inflammatory biomaterials, human or porcine. Azithromycin will help locally and orally, and obviously the flap management and the suture. But if we want to make a medical treatment, we need to enhance, of course, the immune response, and we need to inhibit the prostaglandins production. What is the pathway? Inflammation-induced production of prostaglandin through the cyclooxygenase enzymes. And this inflammation, when the prostaglandin are high level, they will induce bone loss. On the other hand, because there is a biphasic action, on the other hand, if the prostaglandin are at low level with non-steroid anti-inflammatory drugs, then we will need bone growth. I want to show you some cases made several years ago. The proposition was to give aspirin with or without fish oil. And this is the experience from Dr. Urdaneta. He was following patient with peri-implantitis, but just this patient were getting aspirin or an ibuprofen because of cardiovascular protection and low back pain. And he found that after 6-8 years, the bone was coming back slowly. This is interesting. But if we add to the NSAIDs fish oil, then the bone is coming back much faster. 6 to 8 months. This is the concept of osteo-immunology. Reducing the inflammation, reducing the prostaglandin. And then, if we want to treat medically a peri-implantitis, the way should be the use of immune force and aspirin at 160 milligrams per day. It will be enough to be anti-COX-1 and COX-2, but we will avoid the side effects from the aspirin. The lesson 4 from Osteo-Immunology is the quick recovery. What is my benchmark when I test a protocol? I know because I started my career with surgery. A fracture of tibia will heal in 4 weeks, and the tibia will be loaded after 6 weeks in total. It means that the bone healing needs 6 weeks. Simply. Not 3 months, not 6, not 9, as some people they advise. This is a socket management with bone and the whole protocol without collagen, just PRF. And after 2 months and a half, the bone is very good. There is no granule visible, but 2 months and a half is too much for me. Can we do it in 2? The answer is yes. We can meet good bone formation after only 2 months. But 2 months is still too much. Can we do it in 6 weeks? The answer is yes. Yeah, we can meet a full bone healing after 6 weeks because we did everything well. We don't need more than 2 months to reopen an augmentation in the maxilla, even if we didn't use any collagen. We don't need to wait more than 2 months in a vertical augmentation in the mandible because of the osteo-immunology protocols. Even after only 7 weeks, we can see the quality of the bone. This case is a huge defect. just by using the sticky bone and PRF, no collagen, and look at the bone healing after 2 months. Of course, the bone is not very dense, but what is the objective? It's just to place the implant, to have enough volume to place the implant. As we don't load them, we don't care. This is an interesting case after a full peri-implantitis in the maxilla. We managed with the mesh, the fast system mesh. I designed this mesh and this system after my meeting with Mamoto in 2011. And then we used the same protocol in order to make the full reconstruction of the maxilla without collagen. And this is the bone regeneration after 4 months and a half. We waited more than usual because of the lockdown. Otherwise, we would reopen earlier. But again, the implants are placed with a reduced torque. They are not loaded immediately. And when we respect the bone, we will have a very good quality, 50% of new bone, only 20% of connective tissue, despite the lack of the collagen membrane. In the vertical augmentation, only 10% connective tissue. What does it mean? If you are not inflammatory, you will not have connective tissue. But respecting also the non-pressure implant placement, non-immediate loading, then 3 years later, we have still the bone. There is absolutely no resorption in any implant. But, of course, patient waited 8 months without denture. This is the condition. Because if you put a denture, it will press the bone and it will kill the bone. We can do today regeneration with mesh, and this is the quality and the outcome of this kind of bone augmentation. But when we have inflammation, we use a collagen membrane. We don't have any doubt that when we meet an indication, we use a collagen. And we will meet the same outcome. This is a surgery we did in June. It's a live surgery. We did during the SciFac Congress in Nice. Using a mesh, this is the mesh from the fast system. We just need 2 screws to fix the mesh, and then we can go to place the sticky bone. It's very easy to fill with the sticky bone. We did not use any collagen, and only PRF, and closure as well means apical mattress suture technique. So let's go to see the reopening only 3 months later. The mesh removal is easy because this mesh cannot be osseointegrated. Then it's very easy to remove. It's not adhesive. There is no inflammation, no fibrosis. And then we go to place the implants. Reopening without the mesh and then the implants. Another case with the mesh and the spikes unit. This is a 3D augmentation, but it's very, very easy. So it's time to conclude. We need to think Osteo-Immunology. from the morning to the evening, and from the evening to the morning, all time. You have here a QR code that can allow you to see again this lecture. And if you need to get all the protocols in PDF, just write me an email and I will reply with pleasure. Thank you, my friends. Enjoy.